In this short video, I'll discuss why pencil beam fails in general, but especially in proton therapy. First question that comes to mind is why dose calculation is hard in proton therapy. Protons are very sensitive to what they pass through. A little bit of change in the medium, that is, if it encounters different material in the medium, the position of bragg peak, the bragg peak is the position where almost all of the energy of proton gets deposited, shifts. So the strength of proton therapy, which is to deposit energy at almost all of the energy, that is all the dose at a particular location, is also its biggest weakness. For example, if my, let's say, bone slab, or let's say the tumor is in between this rectangle, a little bit of air cavity here can shift the bragg peak from this location to this location, or a little bit of change in material, let's say water comes in or bone comes out, comes in there, so the bragg peak can shift from here to here. So the range is very delicate. Speaking of range, proton stops abruptly. A few millimeters of error in predicted range can shift the bragg peak out of the tumor, or maybe put it inside the dose inside the organs at risk, which we do not want. Heterogeneity, human anatomy isn't just water, it's bone, lung, air cavities, which changes proton energy loss as the proton traverses through those mediums. So it makes the dose calculation quite non-intuitive. It becomes very difficult to calculate where the dose will end up. Next come density. We use density to get the stopping power from CT images. We get density, from density we get Hounsfield units, from Hounsfield units we get the stopping power ratio. And that conversion is imperfect and very much patient dependent. The biggest one is multiple Coulomb scattering. Multiple Coulomb scattering widens the beam laterally, especially after, if there is some heterogeneity, if the proton has been traveling through muscle, that is soft tissue, and then suddenly encounters bone. Small angle, even small angle scattering will have large consequence. The protons will spread a lot, which is also again non-intuitive but has bigger clinical consequences. And the last one, all of this adds up, and upon that we also have, if when we are putting the patient on the couch, there is some error in the setup. If the patient moves a little bit, the dose may fall inside or outside of the tumor. CT noise, calibration, and physics models, everything adds up, and the changes is not linear. If there is error of 1 to 2%, let's say the patient moved by 1 to 2%, there could be a big difference where the dose will end up. It's very delicate. So what pencil beam algorithm assumes actually? So the problem with pencil beam algorithm is that it assumes simplified Gaussian spread of the beam. Specifically, like this water droplet, if my protons are coming, it will model the spread of the protons as a smooth Gaussian, like water droplet. It averages the energy loss in the medium, which is not actually happening. If my, let's say if I have a bone over here, it will just do the density scaling, and which is not correct and accurate. That's the problem with pencil beam scattering. It simplifies the scattering. It just takes the average of it. The energy loss and scattering, it ignores the stochastic straggling. That means the bragg peak ends up, in reality, bragg peak ends up somewhere else, but pencil beam says it will end up here. So that's one of the difficulty. Then we have limited lateral transport. That is, a lot of dose are leaked around the heterogeneous, which pencil beam is not able to model properly. Heterogeneity comes, pencil beam fails significantly, and it only works in water like media because it's homogeneous. In homogeneous media you can have um, you can average the energy loss. You can take the simplified scattering model um, like Gaussian, and but when there is heterogeneous media, for example bone, air, it underestimates the lateral spread. Now the question is why pencil beam breaks down. We already discussed that, and from here you can see here there is the bone. In this region there is bone, and at the interface the pencil beam just simplifies the scattering, the simplifies the lateral spread actually. But in reality at the interface the stopping power changes, and the deposition of dose changes very specifically, which can only be modeled by Monte Carlo, which are these curves. And pencil beam is just simply doing the density scaling and gives us a smooth curve, which is not the case. So in heterogeneities, protons scatter and slows down stochastically, which pencil beam is not able to model. At the interface, the multi-coulomb scattering increases. That's why we get this, not this behavior, which of course pencil beam is failing to model properly. Next we have energy loss fluctuates. We know pencil beam averages the energy loss, but because of heterogeneous media, the energy loss, there will be big difference. For example, the stopping power in bone will be completely different than the stopping power in soft tissue, which is water. So you cannot average the energy loss in between at the interface of that region. And then pencil beam is not able to um, incorporate the extra dose which comes out outside of the beam, pencil beam, which is from the secondary particles, which gets generated mostly secondary protons and electrons and neutrons, but not that much. And the last is interface effects dominate. At tissue boundaries, lung, that is lung and bone, air tissue, all these effects spike, and simple model like pencil beam, it fails. So as you can see at the interface, because of multi-coulomb scattering, energy loss, which pencil beam averages, which leads to underestimate of dose at the interface. I hope, well, that was all.